Thank you, Zori. Hi, everyone. For those of you that are joining us for the first time, a big hello to all of you. We designed this session to be more interactive and very intimate and in a much smaller group so that we are able to speak with our guest and our speaker one-on-one and make it more of a conversational event. So thank you very much for joining us. We do have Shannon with us, and we have so many questions for Dr. Westin. So Shannon, welcome to OC 360 Live.
Thank you so much for having me. Very excited.
So Shannon, we do have a lot of questions. So, and we welcome everyone to type in your questions in the chat window as we go. The way we designed this hour is Shannon was going to take your questions and answer some of those that we have already received. And then if we have time, she's going to do a quick tutorial of clinical trials, how to access, what to look for, how to search for it, and everything related to that. But before we get to it, I will start off with my first question, Shannon, is that at what stage in the journey of this whole ovarian cancer journey should someone consider clinical trials? And can you just briefly discuss the merits and challenges of clinical trials?
Sure. I think things have changed a lot. It used to be that patients would be considering clinical trials when all of the standard of care options were gone. But that really has changed because we have a number of clinical trials that are occurring right from diagnosis. And so you have the opportunity to get access to the potential new standard of care. I think a lot of these trials that are done in the upfront setting are typically providing something novel in addition to what you would already get, if you're getting your usual care with your surgeon and your GYN oncologist. And so it's an exciting opportunity for patients because you're at the very least getting what you would get anywhere, and then potentially you're getting something that may add additional benefit to you. And so that certainly has been a big change over the last years as we've looked at more kind of exciting targeted therapies and things like that. But there really are opportunities to participate in clinical trials really at any time point along your cancer journey. So we have trials for people that are in kind of remission, that we're just looking to see other things we can do, like exercise or, diet, things like that, survivorship studies. There's opportunities, of course, for treatment in the recurrence setting. We're doing a lot of work with maintenance now. So we've got the cancer to go away, and now we're giving you something else to try to keep that cancer away. So, it really is very exciting for patients that there are so many kind of opportunities along the way. And, your physician will help you find those opportunities, although, time permitting, I'll show you how you can kind of own those decisions as well and do some searches on your own. Now, I think benefits, and I think you were asking about kind of pluses and minuses of clinical trial.
Mm-hmm.
Yeah. So, I think that I kind of already mentioned a little bit of the benefits that as I see it, again, you're taking what you would already get and potentially adding something that may help you more. The trials that we're doing are, we know that especially in the upfront setting, we can get patients to no evidence of disease in about 80% of the time. But unfortunately, that this disease likes to return. And so a lot of what we're doing with these clinical trials is trying to keep that cancer away and get more cures. So, having the opportunity as a patient to participate in that is really, exciting. And of course, the goal is to try to do those things without having any additional risk or side effects or toxicities. And so that is really the kind of the negative side of things, right? Is that when we add new treatments or when we try new treatments, there may be unexpected side effects or adverse events. And so really when you're reviewing these trials and thinking about if you want to get involved, you want to make sure you're querying the study team about what they know about these agents or what are the potential risks to you. And you have to decide kind of, weighing risks and benefits, what is kind of the right fit for you or what's the right choice for you. I think the other benefit of clinical trials or the positives of clinical trials is that not only are you getting help, but you could be helping your sisters in arms. So you could be helping others. And so, that really gets at that altruistic nature. And of course, the bottom line is you want to take care of yourself. But, to be a part of this research and to move the field forward is a really neat opportunity. I think that the negatives are, a lot of times clinical trials are a little bit busier. There's a little bit more for you to do, maybe more visits. or blood work or things like that. When we're designing these trials, we try not to put an undue burden on patients. And we have people like Ranzi that sit on committees for us that review our trials and help us make these decisions and talk about, what would patients be willing to go through, what things are too much, what's worth it. And so we do try to take all of those things in mind when we're designing these trials, but it does sometimes require more visits and more work on your part. So those things definitely can be a little bit of a burden. But with that being said, because you're being seen more often, you're kind of being watched a little closer. So you have, direct access to the trial team. And a lot of my patients love that because they have a phone number that they know that nurse is on the other line, and that nurse will pick up, and they can get their issues addressed right away. And so, I think there are pluses and minuses on it, but I think overarching the benefits well outweigh the negatives.
Perfect. Just jumping into questions that we have received from our overcomers. The first question was, the fear of recurrence is topmost on mind for most of our overcomers. So could you discuss the statistical percentage for each stage and provide any guidance you may have related to this?
Sure. I think the bottom line is that the risk of recurrence goes up with rising stage, right? So early stage is really where we get the majority of our cures. And that's why there's quite a bit of research going on around ovarian cancer screening and trying to identify this disease as early as possible, because when we do that, we definitely have better outcomes. With that being said, if I lump early stage together, right? So stage 1 and stage 2, it really does depend on kind of the risk factors. And so low risk would be lower grade, meaning that the tumor doesn't look that aggressive, okay? Would be only in the ovary, right? So completely just in one ovary and not spread anywhere else. Also, the cell type matters. So what does the cancer look like under the microscope? And some specific cell types like clear cell, for example, or high-grade serous can be more aggressive and more likely to come back than some of the other cell types that we see. So with low risk ovarian cancer, the risk of recurrence is probably somewhere around 5 to 10%. Okay? So it's still there, but it's very low. For a higher risk but early stage group, it's going to probably approach around 20%. Okay? And then when we get into the later stages, stage 3 and stage 4, a lot of it depends on how bulky the disease is, how much disease is there. Because you can have someone that is a stage 3 that had just teeny tiny little nodules outside in the abdomen, still stage 3, but not that much disease. And then you can also have someone that comes in with huge, bulky, thick disease, very symptomatic, that's still a stage 3, but those patients are very different. Okay. So for the kind of lower, not as bulky disease, stage 3, it's probably around a 60% chance of recurrence. So still awfully high, but it pushes upwards of like 80% if we're looking at somebody that has kind of bulky stage 3 or stage 4 disease. And so this is why there's so much interest in the research that I was just discussing, is that, even in those patients with bulky stage 3 or with stage 4 disease, we can often get them to no evidence of disease. We can have a evidence of a complete response on our imaging after the combination of surgery and chemotherapy. But we know that risk is there, that high risk chance of the cancer coming back. And that's why we're really seeking out things to take that positive outcome and extend it and to get more cures.
Perfect. Before I move into the next question, are there any questions from the folks that are watching that you would like to ask Dr. Westin directly? Anyone? This is your forum.
And I would just say, while people are kind of unmuting, that, I'm happy to answer any question I can. We try not to answer specific questions related to your case. Again, we are recording this, and so, this is if personal details, just be mindful of that. And also, it's hard for me to give you specific medical recommendations. So just kind of when you're thinking of your questions, be mindful of that.
So while you're thinking of your questions, let me get to the next question that we received. So at what point in our illness we look at doing phase 1 or 2 trials? And with the current approved drugs, is it harder to fight platinum-resistant and BRCA-negative ovarian cancer?
Sure. So, earlier phase trials, it used to be that was definitely, those were trials of last resort when we were kind of running out of options. But now some of these early phase trials, you can get access to treatments that are more focused on your tumor. And what I mean by that is that we're doing a lot of work with things like targeted therapy and immune therapy. And what we can actually do is test your tumor. So we can look at what's going on in your tumor specifically to understand what treatments might work best for you. So the way I always describe it in my clinic is that if you think of it like a base camp and you've got supply chains coming in, food and water and whatnot, we can test your tumor and determine what supply chains your cancer is dependent on. Figure that out and cut it off with a drug and hurt your cancer directly. So this is an area of exploding data and exploding agents. We have so many different things that are under evaluation here. And so if we've done that testing on your tumor and we find something you may be rare that's very unique to your tumor and there's a drug for it, doing a phase 1 trial of that drug could potentially be a game changer for you. Obviously, there's no guarantees, but it is very exciting. And so that's why you'll see more and more people getting involved with phase 1 trials earlier and earlier in their kind of treatment continuum. In regards to the kind of second question around platinum resistance and kind of the new novel therapies with PARP inhibitors, and specifically if a patient has either a mutation in their blood or in their tumor that has like BRCA mutation, now that those patients, there's no question that PARP inhibitors work very well for that population. Not for all of them, but for the majority of them. However, for those patients that don't have that marker, it can be really frustrating because you see these people getting this great treatment and it's not an option for you. So there's a ton of research in this space where we're really trying to understand how to make these drugs work better for patients that don't have that marker. And so there's a number of interesting combination trials that include PARP or other drugs that are trying to find that sensitivity for the population that doesn't have that BRCA biomarker. And so I would say that that's a huge area of interest of research. We have a number of trials that we're spearheading at MD Anderson to do that. So don't be worried, don't feel frustrated. We know that this is an issue and we are trying very hard to change this for you. I think as far as, platinum resistance has always been bad. We know once we're in that space that it becomes very hard to cure a patient. But what we're seeing is that with these new novel drugs, with bevacizumab and PARP inhibitor combinations, that potentially we can extend time. And so we're trying to get that information as quick as we can so that we can bring it to you, the patient, or your family member, and you really change your outcome as early as possible.
Fabulous. We do have a few questions in the chat window. Let me go there. So there's a question which is asking, which combinations of immunotherapy do you find most successful for clear cell? And are you running any specific trials for clear cell ovarian cancer?
Wow, it's like a plant. This is one of my areas of great interest is patients that have clear cell. What we've seen is that, for immunotherapy, which again, this is a type of treatment that stimulates your body's immune system to fight cancer. For immune therapy, when we've given it as a single agent, if we've given just one of the immune therapy agents, we see across all ovarian cancer, an okay response, right? It's just about as good as what we can get with chemotherapy. So about 10, 15% of patients will have shrinkage of their disease in response to this. However, when we tease out the patient population, it does seem that patients with clear cell ovarian cancer have the greatest benefit. Now, these numbers are small in each of these trials. There's maybe 2 or 3 or 4 patients that have a clear cell ovarian cancer, but we see a higher proportion of those patients getting a benefit, even just from a single agent. Now, dual checkpoint inhibition, dual immune therapy is still really in clinical trials. We've seen a few trials get reported. One was combining a drug called nivolumab with a drug called ipilimumab. And again, that was an all-comers ovarian cancer, but there was a population of patients that had the clear cell type. And it did seem that, the combination worked better in kind of all ovarian cancer compared to the single agent. But in that population that had a clear cell tumor, they got the most benefit. There was a higher proportion of benefit to the combination therapy than the single arm therapy in that group. So again, showing us that for clear cell, the use of immunotherapy seems like a good idea. And so to that end, we have a number of trials that are focusing on immune oncology agents in clear cell ovarian cancer. So if you're interested, please reach out. Because we'd love to get you into the clinic and screen and see if it's a good option for you.
On a very different note, you guys need to change the names of the drugs that you come up with. Those are so difficult.
I'm not in charge of that. Well, this is an aside. The companies do this so that it's so much easier to say the trade name, right? They make the trade name really flashy, and I'm not going to say any trade names today, but they take a really long generic name that makes it hard. And so then everyone just knows their trade name. It's a trick.
See, I learned this today, did not know. Okay. So,
I'm not involved at all. I can't say half of them.
Seriously. Next question. If your tumors have become resistant to one PARP, then does that mean that your cancer is resistant to all other PARP inhibitors?
It's a good question. I don't think we know the answer. We suspect yes, because the majority of PARP inhibitors have the same type of activity. They act in the same way. There are there are multiple mechanisms of action of PARP inhibitors, and I won't get into too much of the science, but what we think is if there's resistance to that predominant mechanism of action of the PARP, it won't matter if you use a different PARP inhibitor. With that being said, there's a lot of research that's going on in this space, especially as we know more and more patients are going to be treated with PARP inhibitors and potentially develop a resistance. And at multiple times points during their cancer care, the question will be, can you go back to PARP? Say somebody been on it for 2 years, that clearly their tumor was sensitive to it at some point. Now, maybe it became more resistant. Can you perhaps kill those resistant cells with like a chemotherapy and then go back to the PARP, because perhaps maybe the majority of cells were still sensitive? So I think those are some of the questions that we don't know the answers to yet. And there are some clinical trials around that trying to understand it. So that's kind of where we're at. I will say that we have a number of trials for patients that their tumors have become resistant to PARP that we're adding a drug. So we maybe continue to give a PARP inhibitor and then add something else that's designed to resensitize the tumor to the PARP inhibitor. So there's a lot of interest around kind of why did the tumor become resistant, and can we knock that mechanism out, and can we, basically resensitize the tumor to a PARP inhibitor in combination with something else.
Okay. Before I move on with our next questions, folks that are listening in, do you have any questions that you want to ask Dr. Westin directly? This is an interactive forum.
I'd like it to be.
We would love for you to ask Dr. Westin if you have any questions directly to her. Okay, we'll give you a few more minutes to think. We'll move on to the next question. So this question was from another patient. She is asking that she had her tumor tested, and these are some technical terms, so work with me here, Dr. Westin. So she's saying, I had my tumor tested and my MS is stable and TMB is low. The only alterations were the CRAS amplification and TP53. Yeah, my treatment was not changed by these findings, and it seems to have actually worsened my chances of getting into a clinical trial. Why would that be?
So the end part is a little hard for me to say without reviewing the records. I think that the findings of the tumor are super common for ovarian cancer. Very often we see the test of microsatellite instability or microsatellite stability. That's one way to predict response to immunotherapy. And I would say the majority of ovarian cancers do have an exact type of tumor that you have, where it's microsatellite stable and the tumor mutational burden is low. Okay. And those, again, are just ways to predict potential response to immunotherapy. So that's not a surprise. The KRAS amplification is something that we do see and potentially can drive resistance to other therapies. That's one of those pathways we were talking about. That's one of those, the survival pathways that we were talking about. That's a very common one to see be aberrant in ovarian cancer. And we do have trials that are focused on targeting that abnormality, either alone or in combination with other targeted agents. And so I wouldn't say that that potentially limits your ability to get on trials. Now, I think I'll stop there because it's very hard for me to make suppositions about kind of why your tumor's response to this therapy might be impeding your ability to get on trials, because I would say that a large number of our trials at MD Anderson are for people that their tumor is resistant. That's an area of unmet need, and that's an area where we really are trying to change practice.
Okay. A few more questions from the chat. This question is from Irina, and she's asking that you have mentioned numerous trials to help BRCA negative HRD proficient patients. Can you please expand a little more about these trials, just in terms of examples, status, stages, etc.?
Yeah. So we have a number of immune combination trials that have been developed in our clinic that are basically hitting the immune system in two different ways, either removing inhibitory kind of signaling from the immune system to allow it to flare up, or even, we talk about stepping on the gas and, taking off the brakes. And so doing novel combinations that may help activate the immune system and make it harder for the ovarian cancer to hide from the immune system, which is how it gets away and why it doesn't respond as well to immunotherapies. We also have really cool things that are being done by one of my colleagues, Dr. Amir Jaziri, looking at something called adoptive cell therapy. So that's taking immune therapy to the next level. So instead of, taking the brakes off and just hoping that the immune cells will find the cancer, you actually take out cells and make them smarter and stronger, and then put them back in. So they're kind of like, they have like a scent, like a drug sniffing dog, and they know where they're going. They're not just counting on the immune cells to find the cancer. And so there's a lot of really exciting things that are being done in that area. And then we also have a number of trials where we're looking at patients that have either developed resistance to PARP inhibitors or would not have been expected to have a benefit from a PARP inhibitor because of their tumor's molecular status, and doing novel combinations around PARP inhibitors plus something. So right now we're enrolling on a trial that combines a PARP inhibitor with a PI3 kinase inhibitor, and it can be a lot like alphabet soup. But again, just like we talked about RAS, PI3 kinase is another survival pathway. It's another way the cancer gets away from our standard treatments. And so what this does is we hit the cancer in two places at the same time rather than just one. And we're seeing benefit even in patients that don't have any abnormality in their tumor that would predict response to PARP. And so these trials are actively enrolling, and as we see better results, then we move them into later phase trials. So the last thing I'll mention is along that RAS question, or the RAS side, we've had a combination of PARP inhibitors with a MEK inhibitor that targets that RAS pathway. That trial's nearly done, and we're moving it into a randomized trial now through the National Cancer Institute, which is a cooperative group setting. So it's a national trial now where we'll be looking at the combination of PARP and MEK for patients that have those abnormalities in their tumor, like one of the earlier questions about that KRAS amplification. So that's something that potentially would be a combination that would make sense for that patient.
Okay. The next question would be, can you speak about the CA-125 marker for ovarian cancer? I understand that it's not always a good marker. So how do we look at them? And also for early stage ovarian cancer 1C or 2, high grade, you said that earlier that the chances for reoccurrences is 20%. Can you elaborate what you meant by that?
Sure. So you're right. The CA-125 is not a perfect marker. It's the best thing we have right now. It is it's a marker of peritoneal inflammation, and it can be elevated in ovarian cancer, but also it can be elevated in other inflammatory conditions like an infection, or other things like that. Fibroids, sometimes, benign diseases like endometriosis. These can make that CA-125 go up. So it's not a perfect marker. And that's one of the reasons why it's not been validated as a screening test for people that don't have cancer. There are a number of different studies looking at different ways to follow the CA-125 and to combine it with imaging. But to date, none of them have necessarily found more cancers and have really only put patients through more testing. For patients we know have ovarian cancer, early stage disease, about 50% of patients with early stage disease won't have an elevation in their CA-125. And so that's obviously extremely frustrating and can make it really hard for a patient and her doctor to know, say going into surgery, is this going to be cancer or not? And also finding it, right? So again, it's not a perfect test. Now, in someone that already has cancer, it can be useful if when they were diagnosed it was elevated. That is something that we can follow to determine if the cancer has come back. Again, not perfect, but at this point it's the best thing that we have. Now, in regards to the percentages we talked about with recurrence, it just means that, out of 100 women that have, a higher risk early stage, that stage, say 1C or 2 high grade ovarian cancer, out of 100 women, 20 will have their cancer come back. Okay, so it's just an estimate. And there's unfortunately not a great way of saying, oh, your cancer, because who cares about 20%? If it's you, if you have the recurrence, then it's 100% for you, right? So it's an estimate that we can give you of the likelihood that your cancer may come back. And it's the reason why we watch closely and follow you and don't say, okay, well, we treated you and bye. That's why we keep having visits and exams and, talking to you about your symptoms to make sure that we identify if the cancer has returned so that we can treat it early.
Okay. The next question is, will you share the results of your JarvaDerva clinical trial, DURVA?
Mm-hmm. So that trial was always a small trial, was intended. So for the people in the audience, it was a combination of taking chemotherapy, the standard chemotherapy, paclitaxel and carboplatin, in women that needed neoadjuvant chemotherapy. So they were not able to get surgery first. They were going to get chemotherapy first. And we combined that with a checkpoint inhibitor, an immune oncology agent called durvalumab. And again, durvalumab takes the brakes off the immune system. And so we combined that drug with chemotherapy, got people to surgery, did a debulking, continued the 3-drug regimen, the chemo with the durvalumab after surgery, and then continued the durvalumab as a maintenance once the 6 cycles of chemotherapy had been completed. So it was not a large enough study to say, oh, is the addition of durvalumab better than chemotherapy alone? What we did was we did a lot of tissue collection, both before treatment and after treatment at the time of surgery, and looked to see what things changed in the tumor in response to this combination therapy. And the goal of it was to understand which patients got benefit based on the abnormalities in their tumor, and also what things changed in response to immunotherapy to help us guide future combination strategies, so we could be smarter about what combinations we should be looking at for patients based on what the immune therapy did to the tumor. So that study, the majority of what's been reported has been kind of the molecular aspects of understanding the changes. But what we did see was that the progression-free survival, how long a patient went without their cancer coming back, was as expected for chemo alone. And it's actually what we've seen in some larger studies that have been reported. There was a study with chemotherapy and a drug called avelumab, another checkpoint inhibitor, another immune oncology agent. And that did not improve the progression-free survival. So chemo versus chemo plus avelumab, there was not a benefit in an all-comers population. Now, what we're wondering and what's being done now is trying to see if there's a select group of patients that, based on what's going on in their tumor, might get benefit from that addition. So it doesn't seem that it's something we can just broadly do across everyone, but there are patients that certainly benefit. And so we're trying to understand who that is.
Okay. So this is a long question. So she is asking that I have had several, actually 4 recurrences and regimens, including cisplatin and Taxol, a trial early on with olaparib and cediranib.
Good.
And
Yeah,
also
you got it.
in combination with Doxil, then Gemzar with Avastin. Now the maintenance has recently added Zejula. The hope is to buy more quality time. I am BRCA and platinum sensitive. Is there any data on using the Avastin and Zejula in combination in terms of the PFS, the OS, or the toxicity? I understand next up is platinum and weekly Taxol if the combination described is no longer helping. So those of us with multiple recurrences typically do not qualify for clinical trials. I would appreciate your insights.
Sure. I mean, I think the regimens that you've gotten to date have been very appropriate based on what I heard. I think that the data for niraparib, which is Zejula, and bevacizumab, which is the Avastin, they're small studies. They're small phase 2 studies. They're interesting. And it did seem that the combination was better than PARP alone, but we haven't really brought it into clinical practice yet because it needs to be better evaluated. The olaparib and cediranib that you were on, that was a very important trial, and they just reported results comparing that to chemotherapy. So in patients like you that have a platinum sensitive recurrence, they compared carboplatin-based chemotherapy to the combination of olaparib and cediranib, as well as to olaparib alone. What they found was that they had hoped that cediranib and olaparib would improve on progression-free survival compared to the chemotherapy. It did not. However, if they had designed the trial a little bit differently, they might have tried to show equivalence, meaning that you could get olaparib and cediranib instead of chemotherapy. The reason they didn't do that is those trials are very large. So what does that mean? What it means is it may be that the combination of olaparib and cediranib is just as good as chemotherapy, okay? But we don't know that. It didn't seem to perform worse. So I think that's the question we don't have answered, right? So the bottom line is the current standard of care for patients with platinum sensitive disease is to get a platinum based therapy. Now, for somebody that has a BRCA mutation, you can also use a PARP on its own. Okay. But the combination of either the olaparib and the cediranib or the niraparib and the bevacizumab is not yet a standard of care kind of in this space. In regards to the clinical trials, I think, we are trying to be more open with who's allowed to participate in clinical trials and are trying not to really limit the number of prior therapies. So we do have studies that are for patients with platinum sensitive disease that maybe don't have a strict kind of cutoff for the number of prior therapies. So that's just something to consider.
Okay. Let me see if I've missed any questions. I think there was one which is asking, if you had tumor testing in an early recurrence, is it possible that the tumor has changed over time and that biopsying it again to determine if there's a treatment now more targeted to the new findings? And if this is not clear, if you are here listening to Dr. Westin, you can ask the question to her directly.
Oh, no, I understand. That
Okay,
makes sense.
perfect.
So,
Okay.
the bottom line is we don't know, right? There haven't been a lot of studies kind of doing longitudinal biopsies. So biopsies at multiple time points during a patient's care. And you're right, there's always a wonder, like, should we reserve any type of testing until we really need it, right? Because if we get it now, and then we don't need to make a decision based on it for 3 years, is that biopsy still reflective of what's going on in your tumor right now? The answer is we don't know that for sure. We suspect it mostly is. There's not many changes. There's been some small studies reported. It doesn't seem that there are many changes over time. The hard thing is there can be differences between actual lesions. So say you have your cancer, you have a lesion on your ovary, and you have a lesion on your omentum, that fatty pad that hangs from the bowel. There have been some testing that's shown sometimes those aren't the same. The molecular abnormalities can actually be different between them. So it's a very complex situation. So with that being said, what I've done is, if my patient has had kind of really extensive molecular testing already, we kind of trust that process. If when we're doing treatment, it's not working the way we would expect based on what we found, I have ordered repeat testing. The hard thing is obviously these tests are expensive, and we need to have the companies agree to pay for them, like the insurance companies and things. So that kind of becomes a little bit of a tricky part, is what's our chance of getting benefit from this? And is it worth the expense? And so we really don't know yet, but it is a really good question that is under a lot of, I would say under a lot of study right now.
Yeah, so I think she's adding to your answer. She's just Rhonda. She just mentioned that the testing initially did not include our HRD.
So HRD is I would definitely get that test, because that's a separate test than a lot of the other molecular tests that you can get. So there are tests that just have HRD. So that would be an opportunity. And we've found in general that it gets paid for. And again, I hate to talk about money and cost, but this is expensive, and we have to be mindful of what's going to come out of your pocket. I see someone ask what HRD is. So that's an abnormality that we can look for in the tumor, similar to what we talked about with the supply chains. This particular abnormality is looking at something called genomic instability, which just means how screwy does the tumor look. And if it does look like that, it may predict response to PARP inhibitors. So outside of a BRCA mutation, if your tumor has evidence of homologous recombination deficiency, HRD, then you might benefit from a PARP inhibitor. So that's the reasoning and the rationale for testing for that. So we will often, even in patients that have had a full kind of molecular panel looking for all these different abnormalities, but if they haven't had the HRD test, we will test for that.
Thank you, Shannon. We have another question from Irina, and she's asking, first of all, thank you for your answer about the clinical trials in progress. As a clinician, can you outline a profile of a patient to offer the trial participation to previous history or recurrences and types of treatments, etc.? Or is it easier to say who is not a good candidate? And Irina, if you have any direct additional questions to ask Dr. Westin, this is your forum. You can directly ask her, and that is why we are doing this in a more interactive. That is why we're calling it OC360 Live Interactive, so that you can talk to Dr. Westin directly. Please go ahead. If you have any additional questions, you can ask her directly.
Well, I would say for your question about, who's a good candidate, who's not, I think that you're right. Saying who's not is probably easier. So, the main thing that keeps patients off clinical trials is something called performance status, which is, how active are you able to be? How much time are you spending out of bed and out of a chair? It needs to be more than 50% out of bed and out of a chair in order for you to be safe. And this isn't meant to restrict or keep people off trials. It's meant to keep people safe. And what we found is, if someone is feeling so ill that they're spending all their time in bed or in a chair, it's not helpful to give an aggressive therapy or really sometimes any therapy, because we just make things worse and there's very little benefit. So that's one of the major kind of cutoffs. Other cutoffs are, we look at kidney function and liver function and blood counts and make sure there'll be different criterion that need to be met, and again, it's about safety. If we know this drug can cause really bad anemia, we don't want to start you on it if you already have a lot of anemia. So that's the kind of stuff we look at to see. Some trials do have a strict kind of cutoff for the number of prior therapies you've had, but more and more, as I mentioned, we're allowing multiple prior therapies, and we really stick to that performance status to make sure you're healthy enough. But we don't say, oh, well, you've had more than this amount, you can't go on. So it just really depends on the particular trial.
Speaking of safety, I had a question for you, which is mostly generic in the times of COVID. How has that impacted the clinical trials that you are running, or recruitment, participation? What has changed and what still remains the same?
Yeah. Well, initially when COVID first kind of reared its ugly head, there was a lot of concern around bringing extra people into the hospital and, putting people at risk. And so many of the trials were shut down or on hold. Now we've adapted to our new situation and it's not going anywhere anytime soon. And we obviously want to keep being able to offer these options for our patients and keep moving the field forward. And so we have our basically full complement of research trials open again. Some of the things that have changed, and I think in some ways for the better, is that there's a lot more opportunity to do things remotely. So our research team works from home now. And so they do a lot of the informed consenting and things like that from home. And so what does that mean for you? It means less visits. We can do a lot of things like this on a Zoom type situation and give you the counseling, help you understand the trial, make sure you want to participate. And then you just come into the hospital when we're ready to start. And so it limits your risk.
So this is almost something that needs to stay even when COVID goes away, right?
I agree. Yes. And the FDA has been very open to this right now. What we're hoping is now that they've seen how well we can do, and that's just not our institution, that's all over the country. But now that we've seen how well all these institutions can take care of patients remotely on trial, we hope that there will be allowances for that moving forward. There's always going to be some situations where people have to come in and be examined and that type of thing. But a lot of the stuff we do can be done like this. We can talk over the phone. We can, if you have a rash, you can show me, on Zoom. And so, that has really expanded. So all of the, negatives with COVID aside, this I think has been a benefit to us, is that our institution has really a very well-developed virtual platform now that allows us to meet with our patients where they are. And it's been helpful from people out of the state, because we can meet and talk with them before they make the trip and determine, is there an option for them? And is it worth the travel? Because obviously one of the other big changes has been, we still get lots of referrals, but sometimes people are afraid to fly into Houston or leave, travel through New York or whatever. And that's understandable because these are very scary times. And so I think that's, we've been able to try to do these types of virtual evaluations. And that way we know if you're taking that increased risk, it's worth something. It's going to be worth potentially, coming out to go on this particular trial.
And thank you for mentioning that. We do have a question exactly to what you mentioned, is can a patient out of state come in for a second opinion? And I have tried to come in back in July, but was told that it was not possible.
Yeah, we're fully open again. We are open for business. And so there are lots of opportunities to come out and visit with us now. So yes.
Perfect. So now there's a question from Nina, and she's asking that, actually two, which is a great segue into, we have 15 minutes. I'm not sure if you can do it in 10, 15 minutes, but she's asking that how do we find out about whether or not we're eligible for clinical trials, and how can we find out what trials are available? So this is the training that you were supposed to.
Yeah, let's see if I can share my slides.
How do they find out whether they're eligible for a particular trial? That was
okay.
the question.
Yeah. I'm going to show basically, I'll answer both of those questions. Let's see. All right. I'm assuming you guys can see my slides. Is that true?
I can.
Good. Okay, perfect. I'm going to scoot through. This is a full-on talk, so I'm going to scoot through all of the basics of clinical studies. We'll have to do this another time, and get to kind of a basic step-by-step of ways that you can find clinical trials. Now, I would say, like for us, we have a research navigator. So if you call our department and say, I'm interested in potentially participating in clinical trials, the research navigator will talk through your cancer case and to help you determine if there might be options for you here at MD Anderson. And I think many institutions may have something like that. So just reach out and we'll help you. These are some of the different websites that you can use that will help. I'm going to focus on the National Cancer Institute website because it's a really user-friendly website. It's clinicaltrials.gov. And so I'm going to kind of walk you through how you can kind of search for a given clinical trial. So the first thing
Shannon,
I just,
before
yes.
you move forward, I just want to make sure that everyone is seeing the screen, that it's front and center, and you're able to view the screen. If yes, please let us know. If not, we will try to fix it. Looks like it's good.
Okay, perfect. So, I just basically recently put in ovarian cancer, just in general, and I'll show you how I did that and found over 500 different studies for patients with ovarian cancer, including phase 1, 2, and 3 studies. So how did I find that? So this is what the landing page looks like here, and you'll see find a study, okay? And you can click, you can change here if you want to have all studies or just studies that are actively recruiting. These are just ways for you to reduce the number of hits you get. And then in your condition or disease, you can type in ovarian cancer. And so I did that. And here we found 2,691 studies. Whoa, that's really overwhelming. That's a lot. So let's go back and modify our search. You can see there's a little tab that you can do that. And we can get a little bit more detail. So here, what I did was I put in interventional studies. I don't want a registry study where they're just collecting my information. I want something that is going to be an intervention, a treatment that I can get. Also put, let's just do open studies, right? Let's not do stuff that was originally reported and now is closed, because that doesn't help me right now. Okay, so we typed that in. And then we also can pick the phase. So if you look down at the bottom, it has phase 0, 1, 2. We're going to focus again on trials that are treatments for us now. So phase 1, 2, and 3. And that gets us to 542 studies. Can still be a little bit overwhelming, but you can see that basically it'll have details, and we're going to go into the details in a second. So what if you want to be more specific and you say, you know what, I don't want it to just be ovarian cancer. I want to have a trial with a PARP inhibitor. So you can add that as an other term. And that gets us down to 96 trials. Okay, so that's, again, a little bit better. And you can see here, though, that sometimes it'll have terminated, withdrawn. And so if you go back, you can get rid of those too in your modification of search. And so you can get it down to trials that are actively recruiting. So this is my trial that I mentioned earlier. So the niraparib, which is a PARP inhibitor, and capanlacib, which is that PI3 kinase drug. And so this is a trial that is actively recruiting. Okay, so here's the first, and it says kind of which groups they're looking at. And so we can click on the title and we can get more details. So the first part that comes up is just some additional detail about when the study was opened, who's the sponsor, who's who's collaborating with us. And you can do contacts and locations. So this will show you, where is it open? Oh, well, it's open at MD Anderson and the contact is yours truly. So then you can reach out to that contact, me or others. And what will basically happen if you emailed me, I basically forward your email right onto my research navigator. She'll call you, talk to you about where you are in your disease continuum and if this looks like it could be a trial for you. There's also the Foundation for Women's Cancer. They have a little clinical trials tab. Again, find a clinical trial. So you click on that. And again, you can put in details. So you can select the area, so ovarian cancer diagnosis. You can also filter by location. So you can type in your zip code and see what's near you, which is kind of cool because it makes it easier for you to try to find something that's in your immediate area rather than finding a treatment that's in Hawaii, per se, although that might be a nice place to go for a clinical trial. I would enjoy that. And then you'll get a list of all the different possibilities for you. Again, 712 right now just for ovarian cancer, but you can put in additional details to try to kind of, get that smaller. And this is pretty cool. They have a request a contact. So you can click on that and it gets you potentially a clinical trial navigator in regards to this particular trial. This was just a trial that popped up as the top. So you can request a contact and they'll reach out to you and they'll help you pre-screen. So it's a pretty neat option. And there are multiple other of these that are available and that are in development. So I'll stop sharing.
You have
Maybe,
stopped.
I did. Okay, perfect. That's what I tried to do.
And so I do have a question on the zip code searching that you were just doing.
Mm-hmm.
So when you do that, suppose that you are in a remote location, right? So, and there are, community hospitals around you, not really any large centers. So then when you do that search based on the zip code, you're only going to find very limited trials. And I'm just assuming, and tell me if I'm wrong, but are you then limiting your search based on the zip code because you're not going to get too many based on just where you live? Is that an efficient way of searching, or should you just search by large centers or by your disease?
It all depends on kind of what you are able to do, right? So if you're able to travel, or if you're ready to travel, then you don't need to limit by zip code. It's kind of cool to be able to look first and see, oh, wow, there is something that's really close to me. Like, let me try that first. And then if it's not, feasible, or if it's not an ideal option for you, then you move on and you expand your reach. What I love about that particular option is that they will call you, that they'll contact you. But it's very similar to what you can do with the NCI and get, a contact information of somebody related to that trial who you can talk to and find out if it's an option for you or not.
Okay. Nina, did that answer your question? You had questions on how to sign up for clinical trials, how to find them. I hope that your question was addressed. If not, again, this is an interactive forum. You guys can ask questions to Dr. Westin directly. We do have only 7 minutes to go, but I will ask one question that I had is, typically clinical trials is something that, just from talking to so many survivors as part of what we do, is even though it's very promising and it has a lot to offer, there's always this question at the back of our minds, about clinical trials. What is necessary information? And we get this a lot. That's why I'm asking. And if this is the right thing for me, or is this somewhat risky? What is the challenge, in the sense that is this something that I should be signing up? Or in other instances, we have received questions like, how do I prepare my family, or around the fact that I'm stepping into a clinical trial? What changes for me that now that I'm into a clinical trial? What adjustments do I need to make? So these are all lifestyle, questions, not really specific to medication, but we do receive these questions a lot. And so I thought I would ask you, so you might address for us.
Yeah, I think that all those issues kind of need to go into your decision-making around if that works for you, and you really having an open and honest discussion with your provider. I think this is really where shared medical decision-making is super helpful, of understanding exactly why this is being offered to you, what is the true benefit for you, why is this being suggested rather than a standard of care, and I think in a lot of reasons it's because we have more hope for that, right? That this clinical clinical trial is going to be better than standard of care, especially as we get into third, fourth line treatment. So I think making sure you kind of clarify what the goal is. Are we trying to, extend my life? Are we just trying to, get me some more quality time? Like what is the overarching goal here? And what's going to be different? So if I do this, what additional things am I going to have to do? Am I going to have to change my diet? Am I going to need to, these are the questions that need to be asked so that you can make a good decision and you make sure that you're ready, willing, and able to kind of make the adjustments based on what the requirements for the trials are. I think that's really, it really comes down to having a very open and honest conversation to make sure exactly, you have your eyes wide open about the goals and the potential and, really why this is being offered and, what might need to change. That's what I would say. I don't know. Was there any of the,
that's good.
Yeah, I didn't know if I missed anything because you had a lot of good questions in there.
Yeah, and I think that you did mention this, that you did say that you could potentially sign up for clinical trials at any stage of your disease. So let's say if I'm just diagnosed and I'm coming into this ovarian cancer treatment path, just it's been like a few weeks and I'm looking into trials, that option is still, because it's traditionally, it's thought that, like you said, when you go to the third or the fourth line of treatment, you have gone through the standard of care. That's when people kind of start thinking about clinical trials. What else is there for me? But what you mentioned is even at the onset, in the beginning of the treatment cycle, there are options, clinical trial options that you potentially could review with your physician and see if you are a fit for it. And because that is great information, because I don't know if there is widespread wisdom or knowledge around that.
Yeah, no, I'm a big proponent of getting involved as early as possible, as long as it's the right choice for you. I think that, again, this is where that shared medical decision-making really, comes into play. Like, what is the standard of care? What is the potential of this research opportunity? Because sometimes it's something I talk a lot about interventional trials because that's my area of expertise. But other things are it's watching your symptoms, right? It's like we've got a number of really cool studies that my colleague Dr. Larissa Meyer is heading up, where she follows people's symptoms throughout their cancer care and really is trying to understand what are the biggest issues to patients and how might we intervene and address them. And so for you, it would just completely be participation at that point, right? There's no intervention, although we're notified if you have a symptom that, that you haven't told us about, so there is a potential for benefit for you as far as in your cancer care, but really this is trying to understand the disease better so we can take care of patients better. So that's something that you might think, oh yeah, that'd be fun. I don't mind doing a couple of questionnaires for something like that. Or you might say, oh my God, that's too much work and I'm not getting any benefit. So it just all depends. You have to ask the question of, okay, well, why is this being offered to me? And really, what is the goal for me? Like, is it truly just I'm helping others, or am I going to get a benefit out of this? And then you have to decide what makes sense. And because it can be really overwhelming, because you can often get multiple things offered to you on one day and think, oh my gosh, which one do I choose? Or do I do all of them? Or so I think it really comes down to a good conversation with the research team and your provider to make sure that, you know the goals. But I'm a big proponent of being involved at every step of the way and getting involved wherever you can. Because I find that my patients feel very fulfilled being involved in these things, especially hearing about the results and understanding how we're making changes based on them. I think it's really exciting for people, and they feel like they're part of something.
Wonderful. 1 minute left. Do we have any questions left for Dr. Westin? I know that we have gone through several questions today, and thank you so much for answering.
Yeah, you guys are great. So many good questions.
If there are no other questions for Dr. Westin at this time, I'll just hand it over to Zori to wrap the event for us.
Okay, sure. Well, first of all, thank you everyone for joining us today. Thank you, Dr. Westin. It's always a pleasure to see you. We hope this session has been informative for everyone, and we look forward to seeing you on our next OC360 Live. Please email us at email at kim@ovarcome.org with any questions, suggestions, any topics you would like to see. Do you want us to do this a little bit more often? Anything in particular, we'd love to hear from you. Thank you everyone for joining us, and we'll see you at the next one. Enjoy the
Bye. Thank you.
Thank you very much. Just a quick thing. If I would love to take a screenshot of whoever wants to be on the picture with Dr. Westin. It's up to you. So we'll go with the names. Let's do that.
Show your faces.
Don't be shy.
All right, we'll just take it. Thank you, Dr. Westin. We will see you all at the next episode of OC 360 Live. Until then, keep talking about ovarian cancer. Bye.
Bye. Take care, everybody.
Bye.
Bye.